Wonderful. So today is a very interesting topic. What we all are going to talk about is the relationship of the atrial arrhythmia, atrial fibrillation, and how about the usage of NOACs, especially in not just in the arrhythmia, but especially in keeping in focus of those diabetic patients. Why it makes sense is South Asia is literally the diabetic capital of the world. Currently, it is in China. China has the one of the maximum population of diabetics. However, in coming few years, India is going to be the diabetic capital of the world as well. So what happens is NOACs, yes, I started using. I would say it was around 2010 when I had moved to Netherlands uh, as for my doctorate training and EP training in Maastricht, and that's when I got used to it. So this was about my first publication in which we try to initially compare the dabigatran versus warfarin, which were undergoing the ablation for this. And that was the time I would say, so it was early 2014 we did the submission. It got accepted, got published, and then the editor said it to us like, no, rivaroxaban was already there as well, and it was already revolutionizing literally the way in which atrial fibrillation patients are being managed. So we had to include the data also from the rivaroxaban, and this was our second paper as well, which we published with our colleagues in Australia that moment. And it really gives me immense pleasure to share in front of you that rivaroxaban comparison paper is the one in which is included in the expert consensus document on AF ablation globally. So it is still there, and so with this context in mind, and my expertise being in especially in arrhythmias, anticoagulation, and thrombosis, let's try to go through uh, what we can do, how we can manage them better, and I always believe in saying what do we call it as the better quality of life. See, I always say to all my friends and colleagues, prescribing a medicine or prescribing a treatment, anyone can do, I think. Anyone, I think a person who is just doing MBBS as well. But what is the difference between you and him? The difference is you can do a better judgment call. How you are going to prevent the morbidity, the mortality. This should be our main goal, main aim. So we all are aware that atrial fibrillation as an arrhythmia, it doubles the risk of dementia, triples the risk of heart failure, quadruples to 5 times it increases the risk for stroke. So that's the reason, in fact, 80% of the AF related stroke tends to result in death and also disability. A lot of things has changed, especially since the ESC guidelines, which came recently. So I must say, so this is just the ESC guidelines from European Society of Cardiology. It is not the expert consensus document, which I was trying to tell. Sometimes I try to also joke to my friends and colleagues. So recently, few months back, 3 or 4 months back only, even from Canadian Association of cardiology as well, they released their guidelines, but it referred to only one of my papers. So I was making fun. I don't like the Canadian guidelines. Why? Then I said it, it refers to only one of my papers. Okay, so let's try to simplify it. So European Society of Cardiology has been trying to simplify the guidelines as well. Whenever we are trying to manage these patients, we should try to keep ABC. So earlier was CC, but now it is ABC. ABC in the terms of you should try to anticoagulate them and also try to see, for example, confirm the diagnosis. And not just along with this, there are also NICE guidelines, which has been updated, I would say, just maybe 2 months back or a few months back on as well. A lot of things has changed. I don't want to dishearten you all. I think um, so. For example, Hasbled is one of the common scores which everyone tends to use for assessing the bleeding risk. Now the NICE guidelines say no, you have to use the Orbit score. Okay, so Orbit is like, oh, for old age, if it is more than 75, you give them a 1 score. Then R is for reduced hemoglobin. Okay, then how about the concomitant use of antiplatelet drugs like this? So things will change, but for us, the main thing is we should be able to assess symptoms. Symptoms, how do we assess? So at least whenever I see a AF patient, I always comment on the EHRA AF score as well. So the EHRA AF score is again further classified into class 1 to class 4. So class 1 is those AF patients who will be asymptomatic, okay? And the class 4 are the patients who will be symptomatic even while taking rest. So this is how they get it done. So you should be able to also comment about the comorbidities on the basis of which we also try to do is our risk or need for any anticoagulation. And I am sure everyone is a master of this slide in which it shows that NOACs are recommended over vitamin K anticoagulants, in fact, and the Chatsworth score of 0 in male and 1 in female, there is no need for anticoagulation. But we must review those patients on a regular basis. Periodic review should be done. Similarly, Chatsworth score of 1 in male, 2 in females, oral anticoagulation should be preferred. And this is class 2A recommendation. Similarly, if Chatsworth score of more than 1 or equal to 1 or similarly more than equivalent of 2, the level of recommendation is 1A. Oral anticoagulation is recommended. And as I had said, we should be able to identify the modifiable risk factors. And one thing is I think we all are masters in knowing the valvular AF definition, so no need to tell about that. So, to summarize it and to make it really easier for everyone, prosthetic mechanical heart valves or moderate to severe mitral stenosis, we should always prefer vitamin K antagonists. So, life is all about balancing, isn't it? So, we all do come across, especially a lot of elderly people and all, who are having diabetes, age is there, then the renal impairments and all. So, those are the patients which we have to consider, will they be benefiting from a lower dosage? So, if I'm going to touch about those points as well in detail. So that's why I was telling you that a thoughtful choice is always important. We should always be able to identify what are the preventable causes, what are the causes secondary to which the arrhythmia is happening. If we come across any of these factors, I have come across, I do manage the AF clinic as well. Several centers I have been doing it since my last decade, I would say. And I have really come across, if, for example, alcohol toxicity. So there was a patient, I would say, who had a single AF episode 15 years back. After that, he controlled his alcohol intake. And I was amazed there was no AF episode at all for that patient. Similarly, obstructive sleep apnea. It's not like this that, okay, if I'm admitting a patient for AF ablation, I will not take care of obstructive sleep apnea. If you manage OSA as well in a better way, the AF ablation success rate tends to increase significantly. Let's try to give you an interesting case. 78-year-old male patient, okay, male patient, hypertension since 2001 with urine microalbuminuria, diabetic as well, dyslipidemia, ex-smoker, ischemic heart disease, okay, and the age of ablation was diagnosed in September 2019 with routine ECG. Okay, so already one answer is given in the form of Chatsworth score. Okay, I would always recommend everyone to please use Chatsworth score. So it doesn't mean that if someone is having an atrial fibrillation, you start them on anticoagulation. No. As I always mentioned about the Chatsworth score, you have to correlate with that. If it fits into the criteria class 1A, then you start them on anticoagulation. So what are the other considerations which we are going to give while anticoagulating this patient? And how much dosage would you think? Any comments anyone would like to make so far? Feel free to use the chat box if you want, otherwise, of course, anyone can comment as well. So we do have a wide choice of anticoagulants, especially NOACs. We all are aware that NOACs should be preferred on the basis of various comorbidities and also the complications which can happen secondary to anticoagulation. Now, see, there are few beliefs I have. I always see it like this. Fire is something similarly. For example, you can cook food as well, and you can burn someone as well. You can help someone fire with fire, or similarly, the NOAC anticoagulation is a great thing, but we should be aware as well when to use it, when not to use it, and how much to use and how much not to use. Okay. So, what is happening in these patients with arrhythmias and diabetes mellitus? AF, I said it already. So, what happens is in diabetic patients, it is a long term process in which the patient does get affected and exposed to inflammation, oxidative stress, and also the glycemic fluctuations as well. So, what happens is atrial fibrillation, kidney disease, and diabetes, they all are independent risk factors for the stroke. So that's why we should keep it in mind. They all will have a increasing effect on the predisposition of stroke. Um, I further add up to this thing is if see primary prevention of stroke should be our motive. Secondary prevention and all, mortality tends to go up, morbidity will go up as well. But if we really want to help someone, we should try to take care on a primary prevention. I must confess, stroke is quite a lot debilitating. Okay, I need not emphasize. Okay, I'm sure our audience is quite a lot smart as well about that. So what happens is the comorbid diabetes is highly prevalent and also increases the risk of stroke and cardiovascular death in patients with atrial fibrillation. In fact, in AF, nearly 70% of the patients will die of the cardiovascular causes. Okay, and there's a highly likelihood of cardiovascular death with diabetes. I remember when I was doing my post graduation at Narayana Hridayalaya, Professor Cherian used to say to us, diabetes is coronary artery disease equivalent. So if someone has a diabetes, try to treat them almost on par with someone having a coronary artery disease. Not that start them on aspirin. Okay, primary prevention in the form of aspirin is highly debated, and there are no benefits as well, which has been shown with that. Yeah, thank you. So we will take up all those questions as well in the end. So there are a lot of clinical landmark trials as well, which has been happening through the journey of NOAC so far. So one of the first one was Rocket AF trial, which was very important considering the addition of rivaroxaban to the armamentarium of the therapies which is available to us. Similarly, has been Aristotle study, which was critical for the usage of apixaban, and the Relay trial, which we all are aware regarding the usage of dabigatran. So what happens is, if we will try to look carefully over here, so diabetes wise, we can look clearly, one of the maximum percentage of diabetic patients was enrolled in Rocket AF trial. So Rocket AF trial had the highest proportion of diabetics, okay, among all the patients of the randomized controlled trials. And when there was a sub-analysis was done, we can see it over here as well. So there was a significant number of patients with moderate renal impairment as well over here in the Rocket AF study. So our aim, as I said, it is primary prevention and also to increase or help the patient control their mortality and also their morbidity. So the protection for the risk of stroke also needs considerable consideration of the cardiovascular death as well. So this is the reason when we try to see beautifully in this forest plot, we can see it like this. The patients having rivaroxaban tend to do better, of course, when try to compare it with warfarin itself. And I must say, all these studies have been done in comparison vis to warfarin. Okay, none of these studies has been in comparison to each other. For example, apixaban versus rivaroxaban, rivaroxaban versus dabigatran, or dabigatran versus edoxaban, which is the newest one. I'm aware that in India it is not yet available. So this is what I need to say. Not just that, so one of the key things which we all should say is the US database analysis has demonstrated that rivaroxaban reduces the major adverse cardiac effects and also the male patients in AF with diabetes mellitus. Okay, so that's what I was talking about. And not just that, rivaroxaban has been associated with nearly a 25% relative risk reduction of the major adverse cardiac effects and a 63% relative risk reduction in the male patients with similar major bleeding risk while compared with warfarin. Okay, and as we can already see, the effectiveness and the safety of rivaroxaban while compared with the with the warfarin definitely seems to be quite a lot high. And these patients, if someone is on a NOAC like rivaroxaban, when someone is on warfarin, the adverse effects, as I already said, it is quite a lot less over here. Okay? So there is no doubt about it. NOACs are the mainstay for any of these patients of non-valvular AF as well. So even in this as well, when we try to compare over here about the CKD patients who need dialysis or even on kidney failure as well, they tend to do much better. And what happens is rivaroxaban in fact reduced the risk of worsening of the renal functions versus warfarin patients, whoever were indicated. So, in fact, the choice of treatment could impact the health of the kidneys in the patients with AF and diabetes. Because the diabetic patients, we all are aware, they all are having a higher predisposition for the development of kidney injury and also the development of the renal failure as well. So, on an overall basis, when we are talking about the parameters of renal decline, we can notice already the patients who are on rivaroxaban, the renal decline is significantly lower. So this is a very beautiful forest plot, as we can see it on the basis of parameters of like the doubling of the serum creatinine, the acute kidney injury, the development of kidney failure as well, and it again tends to favor the rivaroxaban rather than warfarin. So one of the other important things which we all keep in mind is what about the bleeding outcomes of these patients if someone is on on these NOACs as well. So when we try to look on this parameter, which we can see for there has been the NOACs bleeding risk was pretty similar in the diabetic or even the non-diabetic, although except for apixaban. So to summarize over here, what we can see is the patients of non-valvular AF with diabetes are at a higher risk of stroke, cardiovascular death, and limb events. We all have to be extra careful for those, of course. And NOACs like rivaroxaban can not only prevent catastrophic events like cardiovascular disease, but also the limb ischemia. Similarly, when we are thinking about the renal protection or the deteriorating renal functions of the diabetic patients, rivaroxaban can also delay the rapid progression of such symptoms. And also, as we can already see, that rivaroxaban has a good or favorable bleeding profile for the diabetic patients. So, if we are trying to go through these, there's no doubt, I think the answer will be much, much clearer when we are trying to take care of these patients. And everyone, you all can go through our lectures or any of these similar points if you would like to be reading or going through those video lectures in your free time, I'll be more than happy to answer any questions. Are there any further questions, please? Okay. Yeah. Okay. Let me go through the chat. Wonderful, Dr. Ankush. Thank you so much for asking this question. Um, I would suggest if someone is really dependent on dialysis, I would like to avoid it. That is definitely one of the times I'll prefer to use warfarin, I would suggest. One can consider using the rivaroxaban as well, but this is definitely one of the times where warfarin may be preferred, in fact. So in diabetic patients, see, as I had said, it is we do expect the kidney disease may develop over decades due to the acceleration of the vascular changes which is happening. So with the rivaroxaban, as I already showed you, the evidence is it will delay the the renal complications for such kind of patients, and that's where the usage of or the benefit of this thing comes. And see, what happens is we all should keep it in mind, as I was also telling you about the cardiovascular risk profile. It's not just we are trying to be bothered about the treating the patient. We are also trying to decrease the mortality, decrease the morbidity, and also, if possible, try to halt the progression of the comorbidities as well, which a patient will be getting exposed to while using these medications. And with rivaroxaban, I must say, one of the important things what we all are bothered is about the risk of the complications, not just complications, how about the compliance? So the compliance seems to be much better whenever if someone is taking a once daily dosage rather than a twice daily dosage.